David Fisher. I'm president of the Sacramento City Teachers Association. Welcome to our forum on safely reopening schools. I am also a second grade teacher and have children in our district. Here to help me welcome you all is Angelica Miklos. Angelica, you want to introduce yourself?
Hi, I'm Angelica Miklos, and I'm president of the Folsom Cordova Teachers Association. We have about 1,100 teachers in our district. Our schools are currently back. Elementary is the only one that's back right now. We're back in the hybrid model.
Thank you, Angelica. So as I mentioned, this is a coalition of the Sacramento County labor unions, and in addition to Sacramento City Teachers Association and Folsom Cordova Educator Association, we also have joining us River Delta Unified Teachers Association, Twin Rivers United Educators, Galt Elementary Faculty Association, Natomas Teachers Association, Elk Grove Education Association, Center Unified Teachers Association, Rolla Teachers Association, the Sacramento County Office of Education Teachers Association, and San Juan Teachers Association. So before we get started, just brief context of our district. Unfortunately, we may have had the first educator that died of COVID in the nation back in March before we knew where all this was going. And since then, we've been shut down and haven't been back in any real in-person instruction. However, we have had at least 55 to maybe 60 positive employees, including 3 deaths. And just a few minutes ago, I got an update that there are 5 more positive cases in our district, and we are not even in in-person instruction. So like I said, none of us could have envisioned we'd be where we are, but here we are. When we know we all want to get back into teaching and learning in person, there are so many things that we can't control, but there are some things that we can control. And you know, one of our core values is that together we're stronger, right? And it's incumbent upon us as educators and collectively as a union and as a community to do whatever we can to make any in-person instruction, wherever and whenever that occurs, as safe as possible for educators, students, and their families. With that, I'm going to turn it back over to Angelica to read the biographies of some of our panelists.
Hey, thank you, David. We have a wonderful panel this evening, starting with Dr. Bob Harrison. He is a clinical professor of medicine and the associate director of the Occupational and Environmental Medicine Residency Program at the University of California, San Francisco. Dr. Harrison also directs the National Occupational Health Internship Program and has led many work in environmental investigations of disease outbreaks. He served as a technical and scientific consultant to federal OSHA and to the CDC's Workplace Safety Research Program. He was a member of the California Occupational Safety and Health Standards Board. We also have Teresa Pistacchini. She's a registered professional engineer and the engineering manager at UC Davis Energy Efficiency Institute and Western Cooling Efficiency Center. For over 10 years, she has conducted applied research in heating, ventilation, and air conditioning systems, including studies focused on California school buildings. Teresa co-authored a recent paper on ventilation and energy efficiency verification and repair program for school reopening. And we also have our moderator today, Laura Curry. Laura is from the California Teachers Association. She has a master's degree in public health from the University of California, Berkeley, and previously worked in the field of occupational health and safety at both UC Berkeley and UCLA. And now David's going to be introducing you to our San Diego delegation.
Thank you, Angelica. Yes, we are very lucky to have a great team from San Diego, including Dr. Natasha Martin, Doctor of Philosophy and Associate Professor, Division of Infectious Disease and Global Public Health, University of California, San Diego. Dr. Martin is an infectious disease economic modeler who develops dynamic transmission models to evaluate the impact and cost effectiveness of public health interventions. She is currently an associate professor in the Division of Infectious Diseases and Global Public Health at the University of California, San Diego, and holds an honorary senior lecturer position at the University of Bristol. She is also the co-director of the Biostatistics and Modeling Core of the University of California, San Diego Center for AIDS Research. Also joining us is Keisha Borden, president of the San Diego Education Association. Keisha has been an elementary educator in the San Diego Unified School District for over 20 years and currently serves as the elected president of the San Diego Education Association. Keisha is a strong advocate for quality public education and working families in San Diego and across the state, and has worked to develop coalitions with parents, community members, and others to improve the conditions of learning and teaching in our local schools. We're also joined by Richard Barrera, board vice president of the San Diego Unified School District. Richard was first elected to represent District D of the San Diego Unified School Board in 2008. He has helped lead the district through the most devastating financial cutbacks in the history of California public schools by pulling together a community coalition of students, parents, teachers, classified staff, neighborhood, business, and civic leaders around a long-term vision of excellence in our public schools. Despite these budget cuts, over Barrera's time on the board, students in San Diego have achieved record high graduation and college eligibility rates, record low dropout, suspension, and expulsion rates, and today rank at or near the top of large California districts in reading, math, science, and social science proficiency. Barrera has also led the district's efforts in securing $8.4 billion, that's billion with a B, dollars for school facilities with successful voter approved bond campaigns in 2008, 2012, and 2018. These bond measures provided breakthrough investments in 21st century technology and environmentally sustainable infrastructure. And he has led the effort to honor the work of our educators by increasing salaries, maintaining affordable healthcare, and increasing effective training for people who work directly with our students. And with that, I'm going to turn it over to Laura Curry, our moderator.
Thanks, Angelica. Thanks, David. Hello, everyone. It's great to be with you this evening. I'd like to bring Dr. Harrison into the conversation. So Dr. Harrison, come on. Yes. Hi there. Good evening. So I'm hoping you can help us make sense of this particular moment we're seeing in California and across the country. So we know in Sacramento County, we still face a widespread level of transmission risk remaining in the state's highest purple tier. And according to last week's California Department of Public Health report, Sacramento had more than triple the purple tier's baseline case rate. And that's after the county gets the credit for its testing volume. So many of us have heard in the news about all of the different tiers. So to get into the purple tier, the threshold is more than 7 daily new cases per 100,000 people on average over the course of the past week. And that's once the county has been given this extra credit for how many tests they've conducted, because we don't want to discourage testing, so the state provides an adjustment for that testing volume. So the purple tier's adjusted threshold for the case rate is 7, and Sacramento County was over 31 in last week's report. When I checked this morning, we had about 7% of ICU capacity across California. And across the state, we've lost more than 21,000 people who are our loved ones, our family, our friends, our neighbors. And we should be especially clear-eyed to the reality of how hard hit this pandemic has been for communities of color and low-income families. The health inequities have been so stark. So Dr. Harrison, this surge seems worse than what we experienced with the wave in the summer. Help us interpret this particular moment in the pandemic, what some of the COVID models suggest for this winter, and what these broader community COVID conditions mean for our schools and safety for our schools.
Nice to be here. Thanks for inviting me, Laura, and the Sacramento Teachers Association. I think about the COVID figures that we all read about as sort of like going from the foothills of the Sierra and then looking at the Sierras in front of us. It's the slope that went like this in the spring, and then again in the summer, rolling hills, and then what we're facing and what this looks like now are the 8,000 to 9,000 foot peaks of the Sierra. The number of COVID cases have skyrocketed. They're still going up, not only in California, but across the country. I have helped establish and manage the UC San Francisco, our medical center, COVID hotline. So our employees, we have about 30,000 employees. If they have symptoms, they can call in and get a test. And roughly between the beginning of February, the beginning of this pandemic, and November 1st, we had about 275 positives. We were keeping things under pretty good control in terms of our positivity rate. In the last 6 weeks alone, we've had close to another 200 cases, just in 6 weeks compared to the 9 months that preceded this 6 weeks. So a tremendous surge in cases attributable to a combination of wintertime, Thanksgiving, and what I think everybody would realize is COVID fatigue. My family was personally caught up in this. I have a family who lives in Minneapolis, and both my daughter's son-in-law and my 18-month-old grandson became COVID positive about a month ago. As I say, they were caught up in the wave that occurred. There was a week in which Minnesota had the highest positivity rates. They're both in healthcare and probably infected my 18-month-old. Fortunately, everybody is fine and has recovered and gone back to work. So about 90+% of California is now in the purple counties in the highest risk zone based on positivity rates. Many counties have substantially rolled back into essentially a shelter at home or shelter in place mode, which is the way we were in March and April. What we're looking for is, again, to flatten this curve by keeping vigilant and doing the same things that we did in the spring. It's harder because we're in the holiday season. There is fatigue, there is discouragement. There's no question about that. I feel it personally. I know my friends and family are all debating, what do we do for Thanksgiving? Now, what are we gonna do for the holidays that are coming up? How can I get together with my good friends for my New Year's Eve party? What is that gonna look like? And I am saying to all my friends and family who ask me, stick it out, stay in place, because what is going to work, we know from the spring, is that by January, February, this is going to, if we do the right things, are going to come back down. We'll talk a little bit about the vaccine later, I think, but between that and keeping adherent to what we know works, plus the vaccine, I think we're gonna make our way out of this.
And tell us a bit of how the background, what we should be looking for in terms of the background community rates and how that kind of intersects with safety in our schools.
Well, first of all, according to state public health guidance, if you look at the colored tiers from yellow on the one hand to purple, the worst positivity rate on the other hand, it drives the reopening of our communities and our schools. Because there is a relationship between the positivity rate in the community and the risk within our schools. I think of schools, obviously it's a workplace, and I come from an occupational health background, so I'm used to chemicals in factories, injuries in more dangerous workplaces. The school is obviously a workplace, but it's unique because it also has children and then families that intersect with their children. So it's really a triangle, a trifecta. I think, Laura, you taught me that about 20 million, or about half of all Californians, are affected by our schools. Some directly, obviously we work in our schools, we have children in our schools, but we also intersect with other people because we can't get back to work because of childcare. About half of all Californians are in some way influenced by the schools. So I think it's pretty clear that if we're going to think about how we can safely reopen schools, and once they reopen, keep them safe, it is very much influenced by the community positivity rates.
So let's turn a little bit about the conditions inside our schools and with our school safety programs. We've heard health experts, including government, public health officials, and university researchers say that schools should use a layered defense against the virus. In Dr. Martin's work at UC San Diego and her presentation she'll share with us, she calls it the Swiss cheese model of pandemic defense, where no one layer is perfect. Each has some holes, but by layering those slices on top of one another, it reduces the overall risk. Researchers at the Federal Centers for Disease Control and Prevention also echoed that approach in a youth camp case study where they concluded that although no one single layer and one single intervention can stop COVID transmission, that a multi-layered approach that included testing and mitigation strategies was able to really prevent transmission and quickly identify campers and staff with COVID to successfully stop the spread. So, you know, we have many educators and parents and community members listening this evening. What are the things that families and educators should be looking for in their school's prevention plan?
So Laura, you mentioned Swiss cheese. I love Swiss cheese, but you know, I like cake also, and I love my 7-layer cake because my mother loved 7-layer cake. It was a special occasion. She had this, you know, chocolate cake. I think of cutting through these 7 layers of this cake. I also teach my students how to remember things, and I think the number 7 is a nice number to remember. So I think of the 7 layers, and all of those need to be in place. If you ask which of these is more important than the other, I'd probably have a hard time telling you. But the 7 layers that I remember are, first of all, symptom screening. So if somebody's sick, they shouldn't be at work. And they should be able to get a rapid, accessible test with quick turnaround time. Ideally, 24 hours, no more than 48 hours while they're waiting to get their test results. Symptom screening, remember that while symptoms are important, don't go to work, about 50% of COVID infections have no symptoms. So symptom screening alone, you can see, is not perfect. The second are the face coverings or masks. COVID, what we've learned, I think, clearly since February is that COVID is spread both on surfaces and also is airborne, ranging from larger particles called droplets to smaller particles, aerosols that can travel longer distances. So face coverings, masks, clearly important. The third is adequate ventilation. We're going to hear more a little bit later about why ventilation is important and what that should look like. Keeping at a distance. So there's this, you know, greater than 6-foot rule at a minimum, although it's very clear from many studies that the particles of COVID virus can actually travel at greater distances than 6 feet, but at least at 6 feet. The next are small groups, which is a real corollary of distance, particularly in a school. If there are 30 children in a classroom, keeping 6 feet apart is not going to be possible. Small groups are also advantageous in a school because if there is an infection, then it becomes much easier to trace and to segregate the children, quarantine them, have them go home if they're in smaller groups. The next, and I think this is the 7th, is testing. There are different purposes of testing. One very important is if someone's positive, doing what's called contact tracing, finding out everyone who's exposed, counseling, removing them from work if necessary. So those are the 7 layers. All of them need to be in place as we think about and plan for schools. Great.
Well, we're going to come back to you in just a second, or at the end of the presentation, Dr. Harrison, for a little preview of the vaccine. So I want to thank you, but hang on, we'll be back to you. And I want to try that cake one day. You'll have to make it. And I want to now bring on our colleagues from San Diego. And also to our viewers, if you have questions, go ahead and put them in the chat. If we don't get to answer them today, we'll make sure we compile those and can make sure we get information out so that to answer your questions. So I want to welcome on this panel, we have Dr. Natasha Martin, we have Keisha Borden, President of San Diego Education Association, and San Diego School District Board Member Richard Barrera. So thank you all for being with us. Dr. Harrison spoke about one of the layers of the cake being testing, both symptomatic and asymptomatic testing. And I know you all have done groundbreaking work, not just on testing, but on all of those layers of the cake. So I want to start first with you, Keisha and Richard, to tell us a little bit about the joint labor management approach that's underway in San Diego. Give us an overview of some of those school safety recommendations that you all are putting in place that have been advised by the expert team at UC San Diego, and describe how the union and the district formed this working partnership with the university. So Keisha, Richard.
Sure. Thank you, Laura. So we're really fortunate that we have a very good working relationship with the district. We've been working together pre-COVID, but during COVID, since mid-March, when SCTA started calling for the closure of our schools, and then our superintendent, Cindy Martin, really stepped out against the orders of our county public health department and called for a shutdown of our public schools. And so since then, we have shared a commitment to basing all of our decisions around our schools on science, not on pressure from the community, not on anything else, but basing our decisions on science. And so when we started bargaining in July around what needed to be in place for our school buildings to reopen, I think both sides of the bargaining table came to the realization that we really didn't know enough back in July. I feel like now I know so much about COVID, but back in July, I don't think either side of the table really had a clear grasp on what really needed to be in place to make sure our students and our school communities were safe. And so in July, we agreed that we really need to call in some medical and public health experts. And luckily we have UCSD right there in our city, and they agreed to help us. And so that's really where this partnership started. And so we were able to come to agreement on what we're calling phase 1, which is limited appointments, where small groups of students are able to come onto our sites for limited time in very small groups, according to our health experts. And so we were able to come to agreements on the safety protocols that needed to be in place. And also over the last few months, we've really been working on a robust testing program for our schools. And again, we can really attribute that to the support of UCSD. I'll pass it to Richard.
Yeah, Richard, so your perspective as a school board member.
Yeah, no, thanks, Laura. And you know, what Keisha's saying is exactly right. I mean, I think first of all, it's important, for, us to make the point that pre-COVID, going back, several years, we've been able to work together as district and union to get through really difficult situations. I was first elected right when we were entering the Great Recession. We've had many, many challenges during that time, and it's not always easy, but I think we've both committed to the idea that if we can get to the bargaining table and listen to each other, we can work things out and move forward in a way that works for not just the district and the union, but works for our students. And so I think with that track record and a relationship, that's been based on trust and confidence in our ability to solve problems together, we entered this COVID challenge, determined that we weren't going to turn on each other. And we know that, so much of this time has been so overly politicized, and the whole notion of, is COVID real, much less than, whether schools should be open. has been drowned out by, a lot of political posturing. And because of that, we think very competing, confusing, and really not helpful guidance, at times coming from different entities. And so, what actually Keisha and SCTA first proposed is, why don't we pull together our own team of experts in San Diego who are going to tell us what the science says and what we actually need, rather than, talk about all the things that we can't do because we don't have, the resources, we don't have the capacity. Why don't we begin the conversation with what do we actually need to do, and then figure out how to make those things happen. And so, from day one, whether it was, how we were going to, move from in-person learning to distance learning in the spring, to our agreement about how we were going to ramp up distance learning when school began, to, how do we work with our most vulnerable students, and then ultimately to, this partnership with UCSD around more robust and regular testing. It's all come from a place of, number one, we know that if we sit down together and think about what's in the best interest of our kids, we can get to good solutions. But frankly, Laura, also knowing that we have to do it ourselves, because if we just wait, for the state or the federal government to figure this out for us, we're going to be waiting a long time. And like Keisha said, the partnership with UCSD has been so critical. We've had a great working relationship with UCSD going back several years, and and Chancellor Khosla has been a big supporter of our schools. And so when we got to the point, both to see if we could convene our panel of experts to give us guidance, and then to develop a testing program, that relationship, I think, especially between our superintendent and Chancellor Khosla, was extremely helpful, because that, I think UCSD had been hoping, to be able to use its expertise to help, the public schools, deal with this crisis. And so they've stepped up to the plate in a major way. And we think that this partnership, this ongoing partnership, is what is going to actually, eventually get us through this pandemic, and whether it's dealing with vaccines or whatever the next steps are, it's something that, we can really continue to benefit from.
Well, that's great. Well, speaking of that testing program, I remember last spring when many of us were just still in shock about this pandemic, and it was just beginning to sink in, and reading a news article about a UC San Diego professor who was wasting no time to put her knowledge and talent and expertise and leadership to work, and putting together and modeling and developing a testing program for a safer path forward. And that was Dr. Natasha Martin. And so we're really honored to have you here with us today. You're still, playing a very significant and leading role in the UC San Diego Return to Learning program. Tell us a little bit about it and share with us your presentation on testing in an educational setting. I'm going to turn it over to you to go ahead and share your screen and walk us through your research.
Great, thanks, Laura. Thanks for the very kind introduction. I actually, since you were just talking about projections, I took the liberty to add a slide. So just a little reminder, I'm actually an infectious disease modeler. I simulate disease outbreaks. We've done a lot of work simulating how to keep UC San Diego students as well as elementary students safe. One of the other things we're doing is we're doing real-time forecasting of the COVID pandemic on hospital resource needs, both at a county level as well as several counties across the state of California. This is work that we just presented kind of a week and a half ago. We simulate, the model simulates multiple counties. We've aggregated them together in a Southern California regional projection. The projections look very similar across other California regions as well. But just to underscore what Dr. Harrison was saying in terms of, on the left-hand side, the black lines are future projections in terms of COVID hospitalizations. The right-hand side are projections in terms of intensive care bed need for COVID. And in the future, the black with no change in behavior, really sort of emphasizing what he's saying in terms of standing at the foot of this mountain and how quickly things can really escalate if we don't change our behavior. And then these other projections down here at the bottom really show the impact that a stay-at-home order could have if people act the way they did back in March. So what we do is we simulate for each county what happened in March, and if that same change in behavior happened again, how it could flatten that curve. And basically showing that with a 3-week stay-at-home order in orange or an 8-week stay-at-home order in blue, we could really flatten and start bending those curves to ensure that we can stay within our capacity. The key here is this is what would happen if we act the way we did in March. I can tell you in San Diego in the last week since the stay-at-home order, we still have, accumulating numbers, in fact, increasing case rates. So we're very concerned about that and really need a concerted effort to flatten this so that we can be in a better position come in January in the new year. Okay. But some of the other modeling we've been doing has been focused quite a lot on schools and prevention strategies, and in particular, thinking about asymptomatic testing strategies in schools. So you heard about a 7-layer cake at UCSD. We actually started with a 3-pillar strategy, but encompassing the layers that you've heard about today. So our pillars, thinking about what we can do to keep campus safe, are risk mitigation, so cleaning and sanitation, masking, physical distancing, but also the structural configurations that Dr. Harrison mentioned, cohorting, reducing classroom sizes, reducing our density in our residential housing on campus, things like that. Our middle pillar is viral detection. So that's both symptomatic testing as well as asymptomatic testing to be able to identify infections early before they can transmit to others, as well as an environmental monitoring program that we're doing, such as wastewater monitoring. So monitoring the wastewater coming out of our buildings to see if it can give us an early heads up that there might be undetected infections there. Our third pillar is public health intervention, so ensuring that we isolate cases early, contact tracing, digital exposure notification, and molecular sequencing, all things to try to intervene on those potential growing clusters. And like you've heard before earlier tonight from Dr. Harrison, these pillars, these layers, they're all interdependent, right? And there's no one layer or pillar can stand on its own. We can't solely rely on testing. All of these 3 things need to be working together. And our general approach here at UC San Diego is that we're adaptive. So we're continually monitoring the data, and our understanding of the situation, and adapting as we go. And as the county situation changes and the general situation changes. So I mentioned I'm a mathematical modeler. One of the things that I do is develop simulation models. We developed a very detailed and tailored simulation model of SARS-CoV-2 transmission on the UC San Diego campus. And we use these models to understand the relative impact of different policies, like dedensification, classroom configurations, maximum capacity, asymptomatic testing, as well as masking and physical distancing and contact tracing. And so we have developed these very detailed network models on campus to try to understand the impact. And we've adapted these models to look at our elementary school settings and try to help inform, in particular, testing strategies among schools. So these adapted models, again, we've applied to K-12 schools, and the specific question we wanted to ask here are, what is the benefit of entry testing? So testing all students at the beginning of a term, just the week of arrival, as well as periodic ongoing asymptomatic testing. And we were looking at testing of both staff as students, and we looked at the impact that those asymptomatic, both entry and periodic testing, could have on SARS-CoV-2 transmission, as well as our ability to detect outbreaks at their earliest stage. So one of the big questions is, why do we care about this? Why do we care about asymptomatic testing? And the critical aspect here is that many individuals do not know that they are carrying the virus and they are infectious because they either have not yet shown symptoms or they never will. And so we know that as we are bringing students and staff back on campus, and as we see an increased amount of community transmission, what we want to do is be able to have an ability to detect these asymptomatic or pre-symptomatic infections as early as possible so that it doesn't spread on our campuses. And so we developed a simplified transmission model. This model takes into account the natural history of SARS-CoV-2 infection. So it tracks individuals through their latent phase where they may not be infectious to other individuals. And then some individuals may be totally asymptomatic, never develop symptoms, but be infectious to others. Whereas a proportion of other individuals may become eventually symptomatic, but have a period of pre-symptomatic disease where they're infectious, but they are not symptomatic, and then proceed into that symptomatic infection. Critically, testing that just relies on symptoms will only identify these symptomatic individuals, and they'll only identify them after they've developed symptoms. And so the idea of asymptomatic testing is what we're doing is we are potentially detecting and isolating individuals from these green boxes, who are either asymptomatic or pre-symptomatic. We're detecting them early, we're isolating them, we're making sure that they limit transmission to other individuals. And so again, we use this transmission model where we simulate contacts between individuals, and we can simulate a certain number of individuals entering our classroom as infected either at the start of term or throughout the term, just because they may acquire infections in the community or at home and bring them into the classroom setting. And we simulate what happens within a school over the course of a term with all of these seeded infections. And we can examine the relative impact if we just have symptomatic testing versus if we have these additional asymptomatic testing at entry, the beginning of the school year, and periodic ongoing throughout the term. So here's some of the results. These slides show what % of infections can be prevented through entry. And here I'm just showing you symptomatic testing only. So the higher, the better. The higher the bar means the more infections you've prevented. 100% means you've prevented all potential infections that you could have. And here I'm showing you 3 bars with different what's called R0. R0, you may have heard in the news, is the average number of individuals that an infected individual transmits to. So the lower the R0, the fewer infections each individual infection causes, so the less transmission there is. Now, we don't know exactly how much transmission there's going to be in a given school. It will depend on all the other measures that you have in place in terms of cohorting and ventilation and masking. So we show here a range of what we think are reasonable transmission rates, or R0s, just to give you an idea of the range of possible benefits. So you can see here that the bar is higher, more infections are prevented if the transmission rate is low. This is good. It means that these interventions are working together synergistically. So if we ensure high masking and social distancing and cohorting, and we provide testing, all those things are working together to prevent more infections. But what you can see here is now I'm showing different bars in terms of asymptomatic testing strategies, moving from every 8 weeks on the left-hand side to every week on the right-hand side. And so you can see that we prevent many more infections with asymptomatic testing, and more infections if we increase the testing frequency from 8 weeks to upwards of, for example, every week. So we prevent more infections if we augment symptomatic testing with asymptomatic testing. So you can see here, for example, that if you test every 2 weeks, you could prevent between about 75 to 85% of all the infections that would occur over the course of that term with your asymptomatic testing program. Now here, this slide shows us the relative benefits of entry testing versus our periodic ongoing testing. So testing everyone at the beginning of a term versus that ongoing testing throughout the term. And what you can see here is, again, the bars are higher, the more testing we do. So if we test every week, we prevent the greater proportion of infections. And you can see here that the less testing that we do, the more benefit we have of our entry testing. So for example, if we test everyone every 8 weeks, then about half of our infections are prevented just through that entry testing sweep, and the other half through our ongoing testing. Whereas over on the right-hand side, if we're testing every week, then of course there's slightly less benefit to your entry testing, because if you don't test them on entry, you're going to just be testing them a week later anyway. So then the majority of the benefit is through your periodic testing. But overall, with most testing strategies, you can see here in the blue, there's still quite a strong benefit of having that entry testing, just to ensure that you start the term with as few infections as you can on campus right in the beginning of that term. And I think this is going to be especially critical if we're thinking about term starts in the winter, when we have a lot of infection in the community, we're coming right out of the holidays, and we want to really mitigate the risk of those infections seeding in our classroom. And finally, the other thing we've looked at with the modeling is how many, with our different testing strategies, how many cases or clusters of infections could we expect after a single viral introduction was introduced to our classroom? So we know that over the course of term, we're probably going to have multiple infections, multiple students coming in infected, just because they will be infected in the community and then come into our classroom. But if that infection results in a cluster of infections, then depending on our different testing strategies, we'll be able to identify that cluster at an earlier stage. And so, for example, in the top here, we can see that if we only do symptomatic testing, we would expect that we would only be, by the time we would detect that there was anyone infected, there may be between 8 to 15 infections already occurring in that from that cluster, because we're only waiting until one of them becomes symptomatic and that symptomatic person gets tested. However, if we provide asymptomatic testing and we increase the frequency of asymptomatic testing, then we're going to reduce the number of infections by the time that we detect that cluster down to, for example, if we test every 2 weeks, we could expect that there would only be 4 to 7 infections by the time we detected that cluster. And so this is really important because, of course, we want to limit the number of potential infections that might occur and be able to identify clusters very, very early on so we can intervene quickly. And so finally, I'll just end on our Swiss cheese model, similar to the 7-layer cake model, just thinking again that, testing is really important, but it's only one layer of that cake or one layer of our Swiss cheese. And it's, working hand in hand with these other interventions that we have in terms of masking, physical distancing, structural configurations, and contact tracing and isolation in order to improve safety on campus. And with that,
oh, Dr. Martin, thank you so much. I mean, the gratitude and hope I felt in the spring when I read about your work is again here. That is fascinating research. So I want to bring Keisha and Richard back on to talk about some of the practical applications of this. So there's such good, rich information coming. Tell us, what does that look like on the ground with union leaders, the district superintendent, and other district leaders staying in touch, talking regularly, and really sharing in the prevention planning? What does that look like in the on the ground, for San Diego?
Well, Richard, do you want to go first?
Well, no, I'll just jump in real quick, Keisha. So a couple things. One is we actually have a weekly meeting with Keisha and the executive director of SCTA. Laura, you participate in those meetings, the superintendent and I, and our own public health folks at the district, to make sure that we're staying on the same page and that we're together monitoring the progress of our work. So, for instance, we just kicked off our pilot of our testing program with UCSD this morning. So we've identified 10 initial schools. Again, small numbers of students and staff because we only have a small number of students who are coming in right now. But with those students and staff who are coming in, we're starting to follow Dr. Martin's model, which is, at a minimum, we're going to be testing all students and staff every 2 weeks. And so the communication between the district and the union with our partners is really critical. And that's both regular ongoing communication that we have away from the table, But of course, at the table as well through the bargaining process, the two sides are working together to, identify what are the right health and safety strategies that follow the guidance of the UCSD team.
Yeah, and I'll just echo that beyond the weekly testing meeting that we have to share updates and progress around testing, we also have an online learning task force where we check in with educators and administrators and district folks to really talk about how is online learning working. And so we'll also be checking in to see how our different phases are working. Right now we're in phase 1 where there are students coming to campus for limited appointments with their teachers. And so we want to use this phase 1 to really make sure that all of our safety protocols and implementation are working, that they're in place and that they're working well. And that really helps to build confidence in our educators around coming back and letting them know that we are all working together to make sure our school communities are safe.
And that's really inspiring. So kind of thinking about, this road that you all have walked with, UC San Diego as a partner, what advice would you give to educators, to school board members about, how to embark on this to ensure a really safe path and a stable path to in-person teaching and learning?
I think it's been really important, our commitment to relying on the science, our common recognition when we didn't know all the answers to go to folks who did have the answers, and being able to admit that and not feeling like we knew what was best. I think that's really important that we recognize that early on. And so I just feel like open lines of communication are so important. Trust. I know that's really hard. Luckily, we had that trust to begin with, but I really think this shared commitment has really been helpful in our work together to come to agreements on some really hard issues and really difficult situations.
Yeah, and if I was to, give advice to school board members, I would say that number one, what Keisha just talked about is critical, that the way we're going to work through this is not to put ourselves in conflict with the people who are closest to our students, with our teachers, with our classified staff, but it's in fact to work together, even when it's hard, to commit to work through these issues together. But the second, big point is, again, like we've said, don't wait for somebody else to solve this problem for you, and we certainly wish that we had a more, coherent national strategy. We certainly wish that we had a more coherent strategy at the state level, but it's our responsibility to do what's right, to both keep our students and our staff safe, and also to make sure that our students are getting the education that they deserve. So in taking that responsibility, that enables, I think, districts and unions to work together to be creative. And when we have a resource, like UC San Diego in our own community, boy, we should be reaching out and trying to make use of that resource. And again, we think that the partnership with UCSD has gotten us to, guidance about, safe opening, has gotten us, to establishing a testing program that's consistent with the model that Dr. Martin, is laying out tonight. But we think we'll continue to have benefits, as we make our way, through this crisis.
Well, thank you for sharing your inspiring story, your partnership between the school district, the local union, and the university. So thanks for breaking the ground and leading the way and giving us, making the path a little easier for all of us. So thanks so much. So now I want to bring into the conversation Teresa Piscicini from another University of California campus in Davis to talk about one of those important layers of the cake or slices of cheese about cleaning the air in our spaces. So as many viewers on this webinar know, that in October, the Centers for Disease Control and Prevention acknowledged that COVID-19 can be spread through airborne transmission. The health agency cited research where people with COVID-19 infected others who were more than 6 feet away in an indoor space that had inadequate ventilation. And we've seen that air scientists, researchers have been sounding that alarm bell and educating us for months. But then, we got that advice from the CDC. Our own California Department of Public Health, in their August 3rd industry guidance, had urged schools to intensify ventilation. The state's public health officials recommend schools do things like bring in more outside air, use MERV 13 rated air filters, and consider use of portable high efficiency air cleaners. So, we're not all engineers. This topic can get overwhelming quick. So I'm so glad we have Teresa Piscicchini here to help break it all down for us. Teresa, can you give us the basics of what needs to happen to improve ventilation and air filtration to really reduce the risk of airborne transmission in our schools, in our classrooms, in our indoor spaces?
Yeah, thank you for having me here. So let's just talk a little bit about what ventilation and filtration are and how they work. So basically, when we're talking and when we're breathing, we're exhaling little droplets and little particles and some of them become suspended in the air. We call those respiratory aerosols, and they can remain in the air for hours. Some fall to the ground, but others remain suspended. And so then we have to figure out how we're going to get those particles out of the air. So if you can imagine, there's little specks of glitter everywhere. How are we going to remove them? And so we basically have two choices. One, we can bring in fresh air from outdoors and dilute what's inside, or we can run the air through a filter to remove those droplets. So those are basically our two choices, and we'll talk a little bit more specifically about those. But I just also want to recognize that although this is becoming really important because of the pandemic, that ventilation and filtration have really significant impacts all the time and have been shown to reduce absence rates in schools and improve student performance. So efforts and investments we make now can help us in the pandemic and also for years to come in that aspect.
Mm-hmm. And so, in thinking about what are some of the different ways that you're seeing that schools are bringing in that fresh air kind of into those classrooms?
So basically, mechanical systems, your packaged HVAC systems generally have an outdoor air intake. The question is it configured correctly, and is it operating as it should be, and is it bringing in enough, right? And so the procedure there essentially is to have a certified test and air balance contractor come in and measure that outdoor air rate and make sure that it's enough for the classroom. Teachers can also use doors and windows when it's nice outside to bring in some extra outdoor air, because as long as it's nice outside, then that's not going to hurt. It's only going to help the situation.
So let's talk a little bit about the filtration side of the equation. So air science experts and our own public health officials here in California recommend MERV 13 filters to clean the air in our building. So first, tell us what a MERV 13 filter rating is. And then we've heard that some school districts are saying that their mechanical systems can't handle a MERV 13. Is that true? And what's the advice that you would give a school district on that air filtration component?
So this is one of the areas I think that sees the most discussion. So MERV is minimum efficiency reporting value. And as the MERV level goes up, the filtration levels increase. And the MERV rating comes from a standard test method that's published by ASHRAE. And so when we buy a MERV 13 rated filter, these are all tested by independent laboratories. And so we can be really confident in what we're buying. And basically, MERV 13 is about the level where you really start to remove these particles in the size range that we're concerned about containing airborne virus particles. And it's not just the virus by itself, right? But they're contained inside little droplets, and so basically you're cleaning the air. I have a little bit of show and tell here. So this is a MERV 8 filter right out of a school HVAC system. Well, it's new, but I mean, it fits in a school HVAC system. It's 2 inches deep. It looks very similar to like what you have at your house. And then you pick up the MERV 13 and it looks basically the same, except that it has more pleats in it. The material has a higher filtration rating, but the additional pleats increase the filter surface area. And so what that does is it allows, so the MERV 13 filter has 50% more pleats, and so 50% more surface area. And so because the material has more resistance, it gives the HVAC system more area to push the air through. And that overall reduces what's called the filter pressure drop. And so a well-designed MERV 13 filter can have a pressure drop actually equal or lower to a MERV 8 filter. And so really when districts are looking at filter selection, I think it's a little quick to judge to say, oh, my system can't handle it, right? When you're buying filters, you can get the, facility managers can request filter pressure drop data and compare filter products they're buying, and then they can test filters in their actual HVAC systems and do some flow rate measurements and make sure they're getting all the filtration or all the airflow that they should be. I will mention, I'm sure one frustration for teachers is that in order to be bringing in outdoor air and in order for that filter to be filtering, you have to run your HVAC fan during the entire occupied hour. And that can create drafts from the air circulating, and it can create noise. And so I know teachers get frustrated by that, but the system really has this purpose for ventilating and filtering that's separate from heating and cooling. And it's really important to keep that fan running all day.
And what, what would be the role of a portable high efficiency air cleaner in a classroom?
Sure. So
or other indoor space?
Yeah. So if, for example, there will be probably some systems that won't work with MERV 13 filters, or for whatever reason that's too difficult. So portable air cleaners can serve as an alternate option. And generally speaking, you want your portable air cleaner to be have a published, what's called a clean air delivery rate rating, a CADR. And for a classroom, you want that to be, I would say, somewhere in the range of 200 to 400 CFM. 400 if you don't have any kind of central filtration, and maybe 200 if you have central filtration, but maybe it's only a MERV 8 filter. And so definitely look for those published ratings to make sure that it's been tested.
So you have spent a lot of your time and research looking at school HVAC systems and thinking about what would help improve that for both in this moment of the pandemic, but as you said, for having good indoor air quality for healthy teaching and learning conditions. And so, you've noted the importance of installing CO2 sensors. Tell us a little bit about what a CO2 sensor is, what it measures, and how it's useful in helping us achieve good, healthy indoor air quality.
So in one study, we surveyed teachers in 94 classrooms and also measured their indoor air quality. And we found that 60% of those teachers in underventilated classrooms were basically satisfied with their indoor air quality, meaning that they had no idea they had a problem. It's extremely difficult. We don't sense it. Like, you feel you're hot, you feel you're cold, you don't feel that you have no ventilation. You just really don't. And so a CO2 monitor is a way to detect an underventilated space. So when we all exhale, we exhale CO2. If you're not bringing in outdoor air, it builds up, and it's basically like a canary in a coal mine. It says, hey, I've got a problem with my ventilation system. And I think there's a real need to create a method for teachers to be able to notice if there's a problem. And so my last show and tell for the evening, this is a example CO2 monitor that you can see as part of a building control system. You can see down there, it says 664 parts per million. And generally speaking, outdoor CO2 is 400. It'll never get below that. and you generally want to stay below 1,000. And so basically, if it goes above 1,000, that's an indicator for a teacher or facility manager to say, hey, you know, we got to go see what's going on with that ventilation system. Maybe something happened, right?
And I've heard you say that it's important to measure that when the room is occupied. Tell us a little bit about, you know, what those measurements mean in an unoccupied room versus a room that has people in it for some period of time.
Sure, we're using basically the sensor, the CO2 builds up when we're all breathing and we're in the space, right? In the absence of people, regardless of if there's ventilation or not, the space will just be at outdoor concentrations, which is 400. So basically, a facility manager walking around an empty school right now with a CO2 monitor would serve no purpose, right? So we need to, this is for when classrooms are actually in use, that we can use them as a, essentially as an early warning system that a ventilation system is not working.
That's great. So thinking about, you know, our investments in improving ventilation right now pay off in the future for improved learning conditions. You and your team at UC Davis have put together a lot of really good, easy to use materials that would be very handy for educators, for parents, for community members. Can you give us a little show and tell of some of those materials you guys have on your website?
Sure, I'm gonna just briefly, I'll show it on my screen, but I'm also just dropped it in the chat. But I really encourage everyone to take, my screen sharing?
Yes, we can see it.
Great. I really encourage everyone take 6 minutes and watch this video. We worked really hard to put everything you need to know in 6 minutes. And I've got a list of what I just talked about here as far as solutions. And if you really want to get into the weeds, we've got a list of some news coverage here, an hour-long webinar, reports, white papers, everything you could want, I think, hopefully.
It's great. I do want to do a plug. The video is a really great primer to the basics of ventilation and air filtration. There are some posters on that website that are very easy. And then for a technical roadmap of all the things that Teresa just outlined, the white paper that she co-authored really is a step-by-step blueprint on how to improve ventilation and air filtration and test and balance that system to make sure it's in good shape. So really want to thank you and your team for putting those things together and making them so accessible for all of us. So thanks so much for all your work and for being with us here this evening.
Thank you.
And so I want to bring back Dr. Harrison to talk about some of the big news that we've been seeing last week and this week that offers us a ray of hope. We know that vaccines are on their way. The first shipments have arrived in California, and federal and state decision makers currently have a draft proposal that school staff, along with other essential workers, would be up next after healthcare workers and long-term care residents. We're going to be hearing more community health education in the days and weeks going forward. But Dr. Harrison, share with us some of the basics about these first vaccine candidates and the promise that they provide.
Thanks, Laura. First of all, the Centers for Disease Control has posted a lot of super useful materials as of last night, and more got posted today. So I encourage everyone to just Google COVID-19 vaccine, Centers for Disease Control. There's really a wealth of information there now. It's really impressive. So as almost everybody knows, in a nutshell, the first Pfizer vaccines landed throughout the 50 states. It's going to approximately 500 or 600 largely larger hospitals that have the capability to take the Pfizer vaccine, which requires a -70 freezer, which most facilities do not have. It's a specialized freezer. Next week, the FDA is poised to approve the second vaccine, which is Moderna, which is much more easily distributed, stored. It requires a standard pharmacy grade freezer, not the -70 freezer. And so that's going to be poised to be approved next week and then probably distributed by the beginning of January. The first groups to get the vaccine are what's called 1A, which are frontline healthcare workers and residents and staff in nursing homes. And then, as you mentioned, there's quite a bit of discussion about who would fit in 1B. The CDC Advisory Committee has recommended, and this also was out yesterday, that frontline or essential workers would fall into the 1B group. So I expect that over the next several months, we're going to see a lot of vaccine and a lot of planning and distribution. Today, the first person in the United States to get the vaccine was Sandra Lindsay, by the way. Sandra is an African-American ICU nurse in Queens. She received it at 9 o'clock this morning. And let me just read to you what Sandra said, because I found it very moving and apropos to this moment. Sandra said, "I have seen the alternative and I don't want it for you. I feel like healing is coming. I hope this marks the beginning of the end of a very painful time in our history." And I think Sandra was talking both about the vaccine and the disproportionate effect that COVID has had on communities of color. And she was speaking about why she wanted to get it. She goes on to say that she hopes that by getting it, she would want people who look like her to know it's safe. She said, "Use me as an example. I wouldn't steer the public wrong." And I think that's such a powerful message from the very first person in the United States to receive this vaccine. She's basically saying this is the long road to recovery. So on a day when 300,000 people have died of COVID in the United States, that's also the tremendous irony of this virus. On a day 300,000 people have died, we have the first person to get vaccinated.
Wow, that is quite moving. Thank you for sharing that. I thank you for sharing that. I want to thank you and all the healthcare workers that you work with. I want to thank all of the experts and the researchers who are on this call with us tonight, who have shared their talent, their expertise, and their knowledge with us. I want to thank the district and union leaders in San Diego for sharing their story. Thank you so much for being with us tonight. And I want to turn it back to Angelica and David to close us out.
Thank you, Laura. And thank you so much to our panelists for such a great science-based presentation. There was so much in there, and we greatly appreciate all that information. This December, we're experiencing some of the deadliest days in U.S. history. But as we were just saying, there is hope ahead. There is light at the end of the tunnel, but we just can't let our guard down prematurely. It's important that everyone wears their mask, stays at home as much as possible with just their immediate family members, and keeps a respectful physical distance from others. Those are some of the ways that we will get through this and make it to the light at the end of the tunnel.
Thank you, Angelica. So I think you can see from this discussion that we have our work cut out for us, but there are things we can do. And to that end, the educators in Sacramento County, our number one priority is the safety of our students, colleagues, families, and communities. We look forward to working with the community and all the districts to make free, regular, on-site COVID-19 surveillance testing for students and staff available here in Sacramento County. You can see from the slides from our presentation how crucial that is. And we call on the state for further investments in public health and strong measures to achieve and maintain health equity with low community COVID rates in all zip codes across the city. With that, I'd like to say thank you again for joining us. Thanks so much to the panelists. That was so informative. If you didn't get your question answered in the Q&A, we'll do our best to make the answers public. And with that, happy holidays, be well, and be safe, everybody.